So then next, after we make sure that this information is in there, we're going to go to our MAR to make sure that it was transferred there. And the reason we want to check to make sure it's in the MAR is to make sure that the pharmacy, because sometimes pharmacy may know someone has a pain pump, and they may go ahead and put it in there, and they may have put it in there prior to it being interrogated and reading that printout, or they may have used a printout from a previous visit. We need to make sure that they're using the dosage and the date from this visit, because patients could have gotten a change in dosage or any change in drug, so we want to make sure it's been done this visit and that it matches on our MAR. The other thing that we want to check on our MAR is that it's not put in as a scheduled med. It should be put in as continuous, so all your time boxes should be grayed out. So you'll see it says intrathecal pain pump, it's continuous, the date matches, and then the dosage matches. So then the next thing that we're going to do is we're going to check our I&O tab and make sure it's in our I&O flow sheet. And when we go to our adult I&O flow sheet, it's usually the last tab on there. And every shift, we need to make sure that we're charting the doctor that the patient is seeing, and then the dosage.
So now the reason why the scanning is important is because if it doesn't appear on the MAR, it'll never generate this adult I&O sheet. So by them putting it on the MAR, it'll automatically generate the I&O sheet. We don't add it, although I see people adding it. Don't add it, because then you'll have about 3 or 4 or 5 of these because people add it. Okay?
So the next tab that we're going to go to that we need to chart every shift is our assessment, and our assessment tab. And under neural axial analgesia, under here we need to document, starting at the top where it says motor function, our Bromage scale. And if you're unfamiliar with the Bromage scale, or if you need a refresher, again on the intranet you can find that scale. And we want to make sure it's important because Donna has found in doing chart audits that sometimes some of these boxes are left open, but it's very important that we document this because it shows that our nurses have been trained and that we are prepared to take care of patients who have these pumps when we're doing the proper assessment. So then next is sensation, and we want to make sure that we're actually touching them to make sure, because sometimes people have had these pumps so long they don't even realize they have numbness and tingling. So if we're actually touching them to make sure that they really can feel it, then we may find that they do have numbness that they didn't realize they had, but then we'll also be able to track it and keep track of the progression. The other reason for this assessment is to make sure if they've had any increased pain or changes in their pain level, if they're having withdrawal symptoms, anything out of the ordinary, because where that pain pump is, you can have movement of it or something like that, and it can cause damage in that area. Is there anything you want to add to that part?
No, so the tubing could actually, catheter can migrate, crack, or break. So that's another reason why you want to do the level of sensation, because sometimes that's one of the subtle symptoms that will change when it does migrate.
She was telling me a story when she was first telling me about the intrathecal pain pump, that there was a patient who had one kinked and it moving around or whatever, it came unkinked, and the patient actually got too much medication and they had to use reversal agents in that to bring them back because they ended up getting too much because assessments weren't done. So then the next part on there is characteristics, and the characteristics is your site. So if it's a patient with a new pain pump, they're going to have 2 sites. They're going to have one on their back and one on their abdomen. If it is an older a patient who comes in with one already implanted, they've had it for a while, you're just going to be palpating on their abdomen. And the reason that we still do that, even though they've had it so long, is because they can get build up fluid in there and end up with infections even years down the line, and it may have to be taken out or something like that. So we want to still make sure that we're checking those sites. So that would be it for this screen. So that is it for all of the documentation. But what if this doesn't show up? You come in, you realize we have a patient who has one of these, but all these charts that we just showed you isn't there. So she's going to go to the training field so that she can show you. We're going to show you how to get those fields to show up. The paper that you received with the yellow on it is instructions on what should happen upon admission. If you keep that with you, it'll help you to remember what we said today and that, but also how this process works. The A team usually admits these patients and they make sure this happens, but if not, then you need to go to your navigator and go to your pre-admission tabs so that you can check to make sure it was added in as a pre-admission medication. For the patient that we were previously looking at, it was on there. But if you have to add it, you're going to go add prior to admission and type it in. And I'll let Donna explain this as she does it so that I'm not talking and then she's ahead of her.
Okay. So if the A team admits the patient, they're going to always make sure it's on the prior to arrival, prior to admission meds. They are excellent at doing that. If it's a newly implanted pump, it will never be there. So you know if you're taking care of a patient that had that implant, that admission, you know that you're going to have to add it before they leave. And we tell you to do it before, if you're the discharging nurse, before you discharge them, because we could have upped the dose several times and you might be putting in the wrong information. So make sure it's the day of discharge and then go ahead and add it to the prior to admission. Now let's say the A team didn't admit the patient, it was interrogated and all of that, but the supervisor interrogated it and everything is in place, but it didn't show up on here because they didn't add it, the A team didn't. You can still go in and do that for those who are pre-existing and we're not going to make the changes. So you'd go in and you'd add intrathecal. I always tell people, if you want to save time, put in intrathecal. If you put in morphine or hydromorphone, it's going to put up every single option for that and you'll be scrolling through that forever. If you put in intrathecal, it's going to show you that first of all. Then you can say, what did Donna say? Just hit the data lookup. And then it's only going to pull up intrathecal meds. So you'll scroll down to whatever is appropriate for that particular patient. So we'll say it's Dilaudid for time's sake. And it's going to pull up a screen that allows you to put in specific information because you know you want that on the med sheet. So I'm going to make up a dose. You're going to know what the dose is because it's your patient. Let's say it's 0.2, 1.2. And then you know it's milligrams per day or micrograms, whichever it is. I always type it in, then I don't have to go through a whole list of options. It's continuous, so you don't want to leave the once on there because if you leave the once on there, it's going to take it away. So you want to put continuous. And then I always like to put the doctor's name. That way when the patient comes back, if they're confused or what have you, I don't want to put Weiss, I'm going to just put it like this. If they're confused or what have you, it'll be on the sheet and you'll know who the managing physician is. In this case, it's Howard Weiss, so that's who I'm going to choose. It'll pop it on there, and so forevermore, unless we change it, it's going to show Dr. Weiss. Last but not least, one of the most important things before you close the screen out is to add a note. And I always like to add implanted, intrathecal, however you want to word it, when you can spell. And then I always will put in, and cap locks, which they tell you never to do, but I do. Do not remove. The reason for that is because if you have a hospitalist or cardiologist reviewing their meds and discharging them, they're going to look at them and say, this patient doesn't need morphine or baclofen or whatever it is, and they'll get rid of it. This way they'll see it's do not remove. It'll make them look at it and see it's an intrathecal pump. It needs to stay on the med sheet. Now, once you do that and the chart is closed, when the patient comes back again, it will show up on their med list. That's the only way we can catch them, and that was one of the issues with the intrathecal pain pumps for patients who had admitted with them. We didn't know they had them for days later because they weren't admitted by the A team. No one asked the question, or they may have come in confused and weren't able to answer that question. So this kind of meets that need for right now. Okay?
Are the admission team nurses, you want them to add this in?
They always do.
Okay.
Yes, they always do.
So if you're doing your own admission, then you would add this at admission. You wouldn't have to wait till the day of discharge.
No.
No.
If it's already in, you all automatically do that because it's a med that they're currently getting. Now look for, because sometimes it is on there. I mean, sometimes we've been making sure that those that have discharged since, you know, I started doing this, even the not the 18, but the ACC or ambulatory care nurses or pain center nurses will make sure it's on there. But we probably miss a few, especially if they come in on the weekend and go home, because they do sometimes.
Alright, so one thing that I forgot to mention to you is when the interrogation is done, there's that printout that was shown to you, there's 3 copies of that should be made. One goes to pharmacy, one goes to the ambulatory care center, and one goes to the HUC. You need to make sure that the HUC scans it in. Unless they're doing something emergent, they need to do it right then, because it's important that that gets to pharmacy as soon as possible. So that will be it for our presentation, unless anybody has any further questions.
Since there is no labels on the top of that sheet, when you are taking that form and you write on the top pain pump reading, then it helps to make sure that it's always labeled pain pump reading, because if it's set down and then picked up, it doesn't have a label on it as to what it is.
I believe what she told me is they're supposed to asphyxiate it onto a bigger sheet so that it's not, and label it so that it's not just that little piece of paper.
Right.
Yeah. The printout actually looks like a tele strip, the old-fashioned tele strip, not the Phillips generated one. So it's a string of paper, and they tear it and mount it on the paper. And they are supposed to write their name, why they interrogated the pump, and put the patient label on it.
And
that every reader should do that, and I haven't seen that they have not done that. I really truly have not. Sometimes I can't read some of their writing, but they really do write on it.
It's there, you just can't read it.
But if
they try
pain pump reading on the top, then it's not just their name, and you know it actually says pain pump reading on it. And because if we don't write that on there, it doesn't say it anywhere.
No, it doesn't.
No.
Doesn't tell you why it's read unless it's written on there. Admission, pain pump reading, MRI, shut off reading, MRI, you know.
Oh, I forgot this is a fake patient.
Yeah.
I was going to show you what they write on it, but it's a fake patient. Never mind.